Okay, now we are starting with renal failure. So what are the objective of this lecture? We will discuss about the anatomy, functions of the kidney, what is ARF, causes, symptoms and management, CRF, causes and symptoms. So as we all know, this is the anatomy, kidneys with ureter, bladder and urethra. So this is what the kidneys do usually. So the functions of the kidney, they detoxify blood, increase calcium absorption, stimulate RBC production by erythropoietin. It regulates blood pressure, electrolyte balance, and renin-angiotensin system. So this is the diagrammatic representation of the unit of kidney, that is glomerulus. So here is the filtration takes place, tubular reabsorption at the PCTA, tubular secretion mainly at DCT, and again reabsorption of water at the collecting ducts, followed by excretion by the renal pelvis. So classification of the renal failure, it is classified on the basis of onset into acute and chronic. Then by site, it can be pre-renal, renal or post-renal. By the output, it can be anuric, oliguric or polyuric. Now coming to the acute versus chronic, acute renal failure is usually sudden onset with the rapid reduction in the urine output, which is usually reversible. It can lead to tubular cell death, but also regeneration. Chronic, it is progressive, non-reversible with the nephron loss, and 75% of the function can be lost before it is not noticeable. Now coming to the ARF, acute impairment of renal function results in retention of nitrogenous waste and other metabolic derangements. It presents with oliguria, anuria, urine output less than 0.5 ml per kg per hour, creatine increase more than or equal to 0.3 milligram per deciliter, creatine increase more than 50% from the baseline. Pre-renal, it is account for the 55% of the cases. Renal parenchymal, that is intrinsic renal, it can account, it is divided, the classification is according to the site. Pre-renal 55%, renal 40%, and post-renal 5 to 15%. So this is pre-renal, before the renal, and this is post-renal, after the kidneys, any site of obstruction, and if it happens in the kidney, then it is renal. Now coming to the causes, it can of the ARF. First, coming to the pre-renal causes, it can be due to hypovolemia, mainly like vomiting, diarrhea, poor fluid intake, fever, use of diuretic, heart failure, or RTA. Intrinsic, it is usually due to the problem in the kidneys like interstitial nephritis, glomerulonephritis, tubular necrosis, ischemia, or any toxins, HUS or sepsis. Post-renal, it can be mainly due to obstruction or like posterior urethral wall, which is very common in children, neurogenic bladder, bilateral renal calculi, papillary necrosis, or cognitive bladder fungus. Now coming to the symptoms of ARF, it is due to decrease in the urine output in 70% of the cases. Usually there will be oligouric diuretic phase, then recovery phase. It presents with edema, mental changes, heart pain, nausea, vomiting, pruritus, anemia, tachypnea, and patient may present with shock, also with cold, clammy extremities. Coming to the investigation, how to investigate, we should go for CBC, renal function test, urine examination, serum electrolytes, blood urea nitrogen, pH of the blood, chest X-ray, USG, and other C3, ASO, ANA, and Doppler USG and or renal biopsy. Now we should go for the urine analysis with BU and creatinine ratio, urine specific gravity, osmolality, sodium excretion, fraction excretion, urine creatinine and protein ratio, urine microscopy to differentiate between pre-renal, intrinsic, and post-renal. Now coming to the management, first you have to make the diagnosis or any life-threatening conditions are there. Identify the cause if possible. Hypovolemia, you have to hydrate. If toxic agent, you have to remove that. In obstruction, you have to relieve the obstruction. Now coming to the monitoring part, while treating the patient, you have to monitor the weight record in urine input and fluid, urine output and fluid intake, BP chart, fluid depletion for renal cause, 20 ml per kg NS or RL, and assess after 1 hour. If there is no output, even there is no output, you have to give the diuretic. If there is CCF or edema, you have to go for the fluid restriction. Diet is important part. You have to restrict the salt intake with 60 to 80 calorie per kg and restrict a protein intake from 1 to 1.2 gram per kg. And now coming to the complications, the life-threatening complications can be hyperkalemia, volume overload, and vascular access. Now coming to the hyperkalemia. It can the clinical features include weakness, lethargy, muscle cramp, paresthesia, hypoactive DTRs, and dysrhythmias. So, what is the ECG? In potassium more than 5.5 or 6, it is usually called hyperkalemia. Serum potassium levels. So, in the ECG, you will see a definite tall peak T wave with wide QRS complex, prolonged PR interval, diminished P, prolonged QRS with T merge sine wave. So this is T waves. How will you treat the hyperkalemia? You can give calcium gluconate, sodium bicarb, insulin, binding resins, Lasix, salbutamol, inhalation, and lastly hemodialysis. Other complications include hyponatremia, hypocalcemia, hyperphosphatemia, severe anemia, hypertension, pulmonary edema, heart failure, metabolic acidosis. Kidney damage lasting for now coming after ARF, now coming to CKD or chronic renal failure. It is the kidney damage lasting for at least 3 months, characterized by structural and functional abnormalities of kidney with or without decreased GFR. So it is GFR is measured, and if it is less than 90, it is renal failure, and these patients require dialysis. Now, the causes of chronic renal failure, it can be due to chronic illness like diabetes, hypertension, or infection like HIV, reflux, nephropathy, polycystic kidney, glomerulonephritis, any type of kidney infection, storage disorders, tumors, or any type of syndrome like Alport. CRF symptoms can be malaise, abnormal breathing, failure to thrive, neuropathy, CCF, anorexia, nausea, vomiting, bony pains due to renal osteodystrophy, seizures, constipation, seizures due to uremic encephalopathy, peptic ulceration, diverticulosis, anemia, pruritus, jaundice, abnormal hemostasis. Complications include acidosis, anemia, hypertension, mineral bone disease, infection, seizures, and growth retardation. Acute problems in chronic renal failure, it is related to either underlying disease, or it is related to end-stage renal disease, or it is related to dialysis. So problems related to end-stage renal failure, it can be metabolic, volume overload, anemia, hypertension, peripheral neuropathy, or abnormal immune function. Treatment include fluid restriction, drug doses adjustment, immunization, antihypertensive, vitamin D3, soda bicarb for acidosis, and blood transfusion for anemia. Definitive treatment of chronic renal disease is renal transplantation. For time being, we can go for the dialysis. So dialysis here is of two types, hemodialysis and peritoneal dialysis. In hemodialysis, it is done 3 to 4 times a week, takes 2 to 4 hours, machine filters blood and returns it to the body. Peritoneal dialysis, it is the dialysis between the abdominal lining, which acts as a filter. So it can be continuous, ambulatory, cyclical, or intermittent. So the indication of dialysis, if there is persistent hyperkalemia, progressive and severe metabolic acidosis, rise in blood urea at a rate of exceeding 100 mg per deciliter per 24 hours, pulmonary edema with fluid overload, severe sodium imbalance, or uremic encephalopathy. So after dialysis, there are also some problems like lightheadedness. The patient who are on dialysis recently can experience lightheadedness, hypotension, dysarrhythmias, disequilibrium syndrome, which can be at the end of the early session. It comprises of confusion, tremor, seizure. It is due to decrease in concentration of blood versus brain, leading to cerebral edema. That's all.